So after discussing the case a little bit, specifically pointing out what words are important, the key words that you're reading that should pop out at you when you're taking your board exams, when you're going through any sort of clinical scenario, when a patient says those words, whether it's in the ED, in the hospital, on the floor, whatever it may be, those are the key words that should pop out at you. Okay? And we're going to recap a little bit, specifically pointing out, a little bit of a summary of the case, and seeing how we go from there. Okay? So the big thing, obviously, is chief complaint. Why did the person come in the first place? Okay. And so the chief complaint in this case, which we all know, is chest pain. Chest pain is one of the most common complaints to ever come through, specifically the emergency room. It could be a number of things, and it is always concerning because some things can kill you, and some things don't necessarily kill you. Okay. So anytime somebody comes in with chest pain, but more specifically any pain whatsoever, this is a little bit of a mnemonic that people use. It's more of an emergency medicine approach to it. It's OPQRST, and these all stand for different things. You've all heard of 7 cardinal symptoms. This is a little bit of an abbreviation to that. So the first one, O, being onset. Okay, so in this particular case, when did the pain start? Were you actually doing something? Things like that. So in this patient, we hear that it's when he is lifting boxes or doing some work, going up a couple flights of stairs. So it's exertional. It's whenever he actually makes his heartbeat go up a little bit. Okay? So it is exertion. Okay? And pardon if the spelling is off. Not the best spelling. P stands for either palliative or provoking. So anything that makes it worse or anything that actually makes it better. So we know with this patient, from the case, that rest is one thing that makes it better. So that is an important thing. As soon as you rest, the pain goes away. He doesn't mention any medications. He doesn't mention any position. He just says rest. Anything that makes it worse doesn't really say, does it? But some things that could make chest pain worse, sometimes when you press on it, people say ow. If obviously I were to make the person stress out and that was an anxiety reduced or anxiety related chest pain, obviously that would be provoking. But in this case, we're not quite sure. We just know that rest makes it feel better. What about the quality? Quality is always important. Is it aching? Is it dull, sharp? Is it twisting, burning? Those are all little clues about what may be going on, what the underlying etiology is. In this case, we know that it's sharp. Okay, very important. So we know that's sharp. Not much else. R is for region or radiation. So for this patient, we know that it's retrosternal. And we also know that it's moving towards the left jaw. Okay, very important. If the pain just stays where it is, it's a lot more localized. If it's moving, something else is going on. Okay? Severity, a question you should always ask every patient, especially with pain. It's the typical 1 to 10, and we all know it's subjective. That being said, it's good to know. So 1 is, it's not much pain. 10 is the worst thing you've ever felt. Most patients, when they come in pain in the ED, will tell you it's an 11. In this case, we actually don't know what the pain is. It seems like he might not be in any pain at all, but we can't judge that. We don't know that. That is a mistake on the case. But as good future doctors, that is a question you will ask every single time. It does change your management. And timing. Timing is a little bit more open-ended question in terms of, does it fluctuate? Is it worse at night? Is it better in the morning? What makes it, is there a certain fluctuation, it's good for 2 days and it's bad, things like that. In this case, again, we're not exactly quite sure. Timing can also be how long does the pain last. We know that it lasts about 2 minutes. So that is a good short amount of time. And one cutoff that I often use, and many people, is 5 minutes. Less than 5 minutes, it's a little bit more benign. Anything that lasts more than that is a little bit more severe, okay? So this is about 2 minutes, which is less than 5 minutes, which should be a cutoff, which we'll talk about soon. Okay? So this is kind of our note-taking, our outline of this case at this point. And so how do we proceed? And so really, the first thing to do, anytime anybody comes in with chest pain, anytime, is you always get an EKG. It doesn't matter whether you think it's lung related, it doesn't matter if you think it's just muscle, you always get an EKG because you never know what's going to show up. So the number one thing to do is you always get an EKG. And why is that? You always get an EKG because an EKG will tell you if someone is having a heart attack at that specific moment, a myocardial infarction, specifically more an ST elevation, what we call a STEMI. So I'll go like this. And let's do the green. We'll do STEMI. And this might be a little bit outside the scope of this course and what we're trying to do here. Point is, if you see a STEMI, all you need to do, well, right away, the first thing you need to do, besides there's 1,000 things going on, is you get the MI team. And why is that? That person needs to go to cath right away. Time is heart. Okay? If you see this, if you see a STEMI on your EKG, they need to go to the cath lab right away. Okay? So this is why you do it first, because you don't have time to do a bunch of different things and then find out later they're having a STEMI. This will kill them, okay? And they need to go right away. So that is one thing that you do right away, okay? Here are the others. When somebody presents to the emergency room, there are things that will kill you within 5 minutes, and there are things that are not as emergent, as I mentioned before. You need to first think, okay, what is going to hurt them within the next 5 minutes? What do I need to do now? If I don't need to do anything now, then I can go see another patient that is possibly going to have something happen within the next 5 minutes. So it's very important to make that distinction very, very quickly. And so anytime you have chest pain, I use PET MAC. And so MAC, or the M in MAC, I'm sorry, we've already gone through. That would be myocardial infarction. So myocardial infarct. That is an acute process. They need to go to the cath lab right away. Okay? So we've already covered that. That is something that you need to do something right now. Let's start with the P now. So PET and P. This would be your pulmonary embolism. Okay? Somebody comes in with a pulmonary embolism, they're going to have a lot of chest pain. Okay? Not usually right away, but most of the time it's a sudden onset. Rest definitely does not make it better. Okay, it pretty much is always there. They're actually very, very short of breath. They're chest pain plus shortness of breath. Okay, it could be sharp, might be retrosternal, might be more off to the side. It usually doesn't go to the left jaw though. Okay, it's usually a little bit more diaphragmatic, things like that. Severity could be similar. Again, we're not quite sure what this is. And this lasts about 2 minutes. Pulmonary embolism again, unless you take care of it, it's going to stay there for until you actually take care of it, or the patient dies. Okay, so pulmonary embolism in this case seems unlikely. No shortness of breath, which would technically be, besides chest pain, the chief complaint in that case. Okay. In terms of E, esophageal rupture. Okay, very uncommon. This is something that usually somebody will be eating or doing something, and it's a sudden onset like this, lots of pain. Usually they'll be salivating at the mouth. Usually they'll be short of breath, because what happens is everything they swallow, all the saliva, whatever it may be, actually goes in their thoracic cavity and squishes their lungs. So you'll see that in the chest x-ray. You'll see some food in the chest x-ray. I actually saw a case in the ED where an old man comes in, sudden onset, was eating spaghetti at home, and came in. We did a chest x-ray, and sure enough, you could tell there was kind of some funky looking stuff in his lung, and we did a CT scan, and sure enough, and the radiology report read it looked like fusilli pasta, I think is what it was. So, point being, this does happen. This is a surgical emergency. They need to go to surgery right away. Other people that get this a lot of times are people that make themselves throw up, ruptures, things like that, people that chronic alcohol abusers, things like that as well. Okay. So in this case, again, it would not be exertional, it'd be a sudden onset. Rest would definitely not relieve it. It'd be a lot of pain, could be sharp. Retrosternal, sure, it'd be substernal maybe a little bit as well. You'd have a lot of shortness of breath, wouldn't radiate to the left jaw, and again, it wouldn't go away like this within 2 minutes. Okay. So unlikely to be esophageal rupture. T would be tension pneumothorax. So tension pneumothorax usually comes in with trauma. Doesn't have to be trauma. And generally this person is very, very short of breath, has a lot of other issues going on. But this is something that needs to be decompressed very, very quickly. Tension pneumothorax is more or less, if you remember, one lung is being collapsed due to air being trapped, basically in the thoracic cavity and the pleural cavity, and basically pushing the lung and also pushing your mediastinum, and therefore compressing the heart and not letting the heart fill. It's actually not compressing the heart, it's compressing the veins, not letting the heart fill. Therefore, basically, your heart can't pump blood, you don't get oxygen in your brain, and you die. This can progress very, very quickly, and although the person will have tremendous chest pain, they will also be extremely short of breath. And this is an emergency trauma situation. The person usually does not come in by themselves, say it's exertional, goes away with rest, things like that. This is not a gradual thing. This is something that will progress very, very rapidly unless you take care of it. So again, very unlikely. Myocardial infarct, we talked a little bit about it. Myocardial infarct, very important to know. Could it be exertional? Sure. People get heart attacks when they all of a sudden start exercising. That's basically what it is. Does it get better with rest? Does it? The answer is no. Okay? And we'll talk a little bit more about this. That's one of the big things. Okay? It usually kind of stays there for a while, and it definitely is more than 2 minutes. Okay? Quality, it could be sharp. A lot of people always describe it as pressure. Okay, that's a textbook. You're going to see that on the board exams, things like that. But when you're in the hospital, don't rely purely on pressure. It could be sharp. I've seen somebody once with hiccups. That was their clue that they were actually having a heart attack, was they would start getting hiccups. It was the weirdest thing. So don't always rely on pressure. But for the sake of board exams, pressure is what the typical keyword that will stick out. Okay. Retrosternal, sure. Left jaw, down the left arm, absolutely. Sometimes it even goes to the right arm, depending on the person, the type of, and vomiting can be there and things like that, okay? So some of these things fit, but 2 minutes, not typically. Usually it's more than 15 minutes. It definitely doesn't go away with rest, right? So again, unlikely, but probably the closest thing we've had so far. A is aortic dissection. All right. How do you know you're having an aortic dissection? Well, first, the person's going to come in. They're not going to say it's exertional. Okay. That person usually has high blood pressure to begin with. They're usually not exerting themselves when they have this, and it sure as heck doesn't go away when they're just resting. Okay. It's still there. It's definitely very sharp, but it does maybe so retrosternal. Does it go to the left jaw though? Not typically, right? It goes through the chest to the back, maybe the scapula, but it doesn't go up diagonally. It goes straight back, okay? And lasting less than 2 minutes or about 2 minutes. I've seen it come and go for some people in terms of pain, but generally that's not a thing either. Okay, so the key word for this generally is going to be sudden, not when they're exercising, sharp, and straight to the back. Okay, not typically what we're seeing here either. So unlikely to be a dissection. And the last thing that will kill you, very quickly, is cardiac tamponade. Okay? And so cardiac tamponade, if you remember, is when the sac around the heart fills with liquid. Could be blood, could be a lot of things. Could be a puncture of the heart, could be a number of things. And really what it does is it doesn't permit the heart to fill. Therefore, again, the heart can't pump. Very similar to a tension pneumo. And therefore you can't get oxygen and so on and so forth. This is an emergency, okay? Pericardiocentesis is needed, unless you think for some reason you have some more time. But what is typically the thing? Is it exertional? No, absolutely not. It could be a number of things, but it's definitely not. You definitely don't just feel it when you're exerting yourself. Does it get better with rest? Absolutely not. It's always there. So it doesn't matter what you're doing, it will always be there. Is it sharp? It could be. It depends why you have cardiac tamponade. If you have a gunshot wound to the area, sure. If you have pericarditis, it could be sharp. So it depends a little bit. Does it radiate? Not typically. It could hurt, it could not hurt. I've seen both ways depending on why you have it. And again, usually if it does hurt, it lasts 1 to 2 minutes. Okay. So again, just unlikely to be cardiac tamponade. The person would generally come in, they would be pretty down, their vitals would be off. They wouldn't just be walking into the ED. So this is just an unlikely. Okay. So out of these, it's very unlikely that our patient is going to die within the next 5 minutes, which is good news for us because we've already spent quite a bit of time just discussing this. Okay. But the point is, keep these in mind anytime you see somebody in the ED come with chest pain. These are the 6 things that will kill you very, very quickly. And the first thing that you should always do is the EKG. Okay? Other things will be chest x-ray and so on and so forth. Okay. So, based on this, we've already excluded some things, but we still have to build our differential diagnosis. So what could it be? So, when you think chest pain, there's really heart. Oh, no. That's not how you spell heart either. Heart. You have lungs. And you have miscellaneous. Okay? And the heart. Let's try to think of what could give you these issues. Well, we talked about one. Pericarditis can give you this pain. Okay. Endocarditis. Not typical, but you can. You can see that. Let's see, what else? You can get ACS, aka, we'll call it, for our sake, we'll just call it unstable angina. That's acute coronary syndrome. Okay? We can have stable angina. What else? There's probably plenty of others. Okay? Lungs. Pneumonia. People don't always think pneumonia causes chest pain, but it sure does. Let's see. Pneumonia. Oh, that's all I can think of. I'm sure some other things will come to me. Miscellaneous. One thing that people never remember is GERD. Acid reflux, inflammation of the esophagus. Esophagus can go, it goes all the way up your chest. You could absolutely get chest pain with GERD. Absolutely. One of the big ones, very common, MSK. That could be anxiety, could be panic attack. So remember, some things are more psychological as well. Another one would be cocaine. Chest pain. Something that you will see a lot of at Boston Medical Center if you continue your studies here. A lot of cocaine chest pain. Okay? So these are some common things that you should think about when you are thinking of chest pain and you've ruled out things that are going to kill the person very, very quickly. Okay? So let's run through this and see what our most likely diagnosis would be. Okay? So let's start with pericarditis. Pericarditis, one of the big key words that you'll remember is always its positional pain, right? Depending on the position of the pain, you will have pain or not. Typically, it's led by a viral infection. If you're from not the Western world, it could be tuberculosis. Somebody that has lupus could have it. It could be some drugs as well that causes it, depending on what you're on. So, that being said, none of that fits. Sharp fits. Retrosternal, sure, but it's not really with rest. It's not exertional. It's not really, so it's unlikely. Let's cross it out with some other marker, which I cannot find at the Oh, there it is. So we will cross out pericarditis. Endocarditis. So endocarditis can come with various things. Generally, you'll see here it'll be drug abuse, things like that. People will get disease, little abscesses, things like that, and they'll get issues with valves and so on and so forth. Point being, usually people will get fevers. People are very sick. Usually they present to the ED, they're septic. They are not going to be able to tell you that it's only when it's exertional and rest, because it's always present. It's always there. We cannot get rid of it. Okay, so this is not something that comes and goes. Okay, so very unlikely again to be endocarditis. Okay, I'm going to skip these two for now. I'm going to go to pneumonia. Pneumonia, again, you're going to have probably some shortness of breath. You're probably going to be coughing some stuff up, unless you have one of the atypical pneumonias. But generally, you're still going to have a fever, even if it's low grade. Like I said, shortness of breath. Sharp, could be sharp. But your pain is definitely not going to be typically exertional rest. What you're going to see is that you're just the lack of energy, you're short of breath when you exert yourself. But it's not typically the pain that comes about. Just unlikely, again. Vitals don't seem to make it seem that way. Other things, GERD. Would GERD do it? Sure, it's possible. We don't have any thing here that says it wouldn't be. The only problem is that, once again, GERD would be after big meals. It would be, you lay down maybe, you would have some acid reflux there. There's no history of it, even though it wasn't given, that would be the case. And generally, GERD would radiate straight up. It wouldn't go directly towards your left jaw. So again, unlikely. MSK, which could be due to the anxiety, panic attacks. Could it be? Sure, it's usually one very, very common symptom. People always come with chest pain, they're scared, but really they have anxiety, and really they just need something stressful happen, okay? One of the best ways to tell if somebody has MSK is when you press on their chest. That is always part of your physical exam. You press on their chest. If it reproduces the pain, you're done, it's MSK. It could be a bone, could be a muscle. I mean, obviously if it's a bone, you're gonna do a chest x-ray anyways. But granted, there's not anything that needs to be done. It's really talking to the person and talking through it and try to find out a way to alleviate that anxiety, okay? Panic attacks is a whole different thing. They obviously need referral. But again, that is something that is not that concerning for you. For the patient, obviously it is, okay? So you have to make sure you comfort the person. But it doesn't seem to fit. It's not exertional, right? MSK would be something, some trauma, would be some type of stressful event, but it's not something that just comes and goes, okay? So unlikely to be MSK. Cocaine chest pain, absolutely. Shows up a lot here. Cocaine chest pain usually is the vasoconstriction of the vessels of the heart, the coronary vessels, and therefore you do get some infarct, to be honest. You will see your cardiac enzymes go up. It goes away with it, after stopping cocaine. We just have nothing here that makes it seem like, unless he's doing cocaine every time he exercises, and then somehow it wears off when he rests, and things of that nature, it's unlikely. We have no history here that says it would be cocaine, there's cocaine use or anything like that. So just unlikely in this patient, okay? I will add here, something that I forgot, that I'm sure you all study is, just losing pens already. Friends, metals? Okay. Alright. So let's talk about Prinzmetals first. As we remember, it's kind of the sporadic vasoconstriction in coronary vessels. Usually happens at night. That's where the timing comes in. Okay, we didn't ask that, but that's why you ask. Okay. It's usually in women. This is a man. And it's definitely not exertional. It's more of a time, random type of thing, usually in cigarette smokers. Again, we didn't ask that. That would be a wonderful history to get, any sort of risk factors for this. Okay. But it's not exertional. Doesn't get better with rest. It could be sharp, and it could definitely be retrosternal to the left jaw. And it is definitely short-acting. But it comes at night, it's with women, and this just doesn't fit the picture. Okay. This is just usually randomly at night while laying down, and usually in cigarette smokers. Okay. So it brings us to the last two, ACS/unstable angina in our case. Okay, we're not going to do NSTEMI. And stable angina. And so let's talk about the difference between the two. Okay? Unstable angina and stable angina are basically just your coronary vessels are occluded. Okay? The degree to which they're occluded is different, leading to a difference in the severity of your condition. Stable angina is never present at rest. It is generally exertional when you exert yourself. And it does go away after a couple minutes or so, or if you take some nitroglycerin and things like that, it goes away. Okay? Unstable angina is when that stable angina that you've previously had has become worse. So it could be happening more frequently. It could be the symptoms are getting worse, or it happens at rest. Anytime it happens at rest, you're already out of stable angina. Stable angina never happens at rest. Okay? Unstable angina is more concerning because obviously your condition is getting worse. Okay? Generally, unstable angina also lasts greater than 5 minutes. This is where that 5-minute cutoff comes in. Okay? Stable is usually less than 5 minutes. Unstable is usually greater than 5 minutes. Okay? And myocardial infarction is usually greater than 15 minutes or so. Okay? Otherwise, it feels pretty much the same. It's going to look the same on EKG. It's going to feel the same. It could come exertional, things like that. Okay? So, that being said, our most likely diagnosis is stable angina. Okay? That is our most pressing diagnosis at this point. Hopefully that makes sense, how we got to this point. Okay? So what would you give to this patient? This is a quick little thing that for those of you that are going to go into emergency or are interested in any type of urgent care, I'll write underneath here. So one thing people like to go by is MONA. I personally don't use it because it's changing all the time. And I'll point out exactly what that stands for. But we don't know the severity of our patient. But generally when somebody comes in with chest pain, and especially if it's actually an MI, that person is going to be in a ton of chest pain. So you actually give morphine. Morphine will actually dilate the vessels a tiny bit, but you actually use it more for the pain because what happens is people have this impending sense of doom, they're in a lot of pain, which creates more anxiety and then actually raises their heart rate, increases demand, and makes the infarction actually worse. Okay? And this patient, not necessary. Doesn't seem like he's in that much of pain. We didn't ask, but he's talking with us. He's doing okay. It's only when he's exerting himself. So not really what I would do here. Oxygen is the next one. A lot of people do this. Why? Because when you come in with chest pain, first of all, you could be having a pulmonary embolism. You could be having a tension pneumothorax. You could be having a lot of things that have to do with the lungs. Okay? But additionally, you want to get the reason that you're having an infarct is because you're not getting oxygen to your heart. And so people think, well, if you increase the oxygen in the blood by increasing the O2 that you're taking to 100%, then the amount of oxygen that actually is getting there is going to be more. Okay? There's a lot of debate on that. Again, it depends where you go, but again, it fits the MONA. The two that we were looking for, based on the case, are you always give nitrates, okay? That will relieve some of the burden on the heart, and you always give aspirin. And that will thin the blood, permitting it to go past that stricture a little bit better, okay? So these two here are what we were looking for, and you give this every time for stable angina. These two you do not for stable angina. You give those more for unstable / for actual myocardial infarction, okay? So nitrates and ASA, okay? Now, before we move on to the next section, there is one question about what is concerning about this. So this is a 30-year-old man, chest pain, that we believe is stable angina. But the case also states that he has a dad, a father, and 2 paternal uncles that had myocardial infarctions in their 30s. That is quite young. So something else might be going on, okay? So try to think about what's going on. Try to describe it. Say what else you wanna try to do, okay? And skip ahead to the next video once you've done so.